Alright, hi guys, welcome back to the channel. This week I thought we would pick up where we left off from 2 weeks ago in the middle of my exams 1 and 2 review for my med-surg class that I used to TA for. So this week the topic will be musculoskeletal trauma and orthopedic surgery. I also want to take a moment before we begin to apologize for not having a video last week because I was in the middle of a 9-day stretch of work and that was extremely tiring for me. So I'm going to try to pick it up from where we left off. So first things first is we're going to be talking about fractures. Now there's several classifications and each of these classifications are kind of the opposite of each other. So to break it down really simply, an open fracture, the first one, is when the bone breaks through the skin. Okay, it's also sometimes known as a compound fracture, and the big thing you need to know about open fractures is that there's a high risk of infection, right? Because if you think about it, your bone's sticking through your skin, there's obviously a higher risk of infection, right? Closed fracture just means that the bone is broken, but the skin is intact. So there's not so much of a chance for external pathogens to get in. Now, what complete and incomplete fractures mean is basically talking about the completeness of the break. So a complete fracture is when the bone is broken all the way through into 2 or more pieces. Incomplete means that the bone is cracked, but it's not all the way through. So it's also sometimes known as like a green stick fracture. You can see that in children sometimes. Now, displaced versus non-displaced is talking about the alignment of the bone piece. So when they're displaced, the broken bone, the ends are out of alignment. So that means they don't line up correctly. So you may require a reduction, which is a realignment. Now, non-displaced means that the bone cracks or it breaks, but the ends are still in proper alignment. So some signs and symptoms of fractures are obviously localized pain, decreased function, inability to bear weight, and guarding. Now, some things that I want you guys to think ahead of is not just knowing the signs and symptoms, but the critical thinking piece. I want you guys to start to develop that, right? Because that's what they test you on. So on a test, if a patient has inability to bear weight, a nursing care plan or thing that we need to look out for is a fall risk, right? So even though it may not say it right out that the patient has an inability to bear weight, it's automatically equals to a fall risk. And you're probably thinking, well, that's so obvious, I know that now, but on an exam, sometimes you might be too tunnel visioned on the question. So I'm just using this time to remind you guys that it's important to see the bigger picture and not just get so tunnel visioned, and keep in mind that there's potentially something else that they're asking, such as like a nursing indication that we could do. Now, what do we do treatment-wise? By the textbook, they're still testing us on RICE, which is rest, ice, compression, elevate, and heat. So the first 24 to 48 hours though, you want to use the cold pack. You can use ice. Then you want to use heats, okay? I know recent studies have shown that this may no longer be true, but since textbooks are usually a couple years behind, we're still going with what they're testing, okay? So this is what they teach you and what they test you on. So you want to use heat after a day or 2 of ice. Another really common testable part of this is to never pick an option that says you put ice or heat directly on the skin, okay? So if you give an ice bag, you never just give like ice directly on the skin. You want to put it in a towel, you want to put it in an ice bag that you have in the hospitals. You never just want to put direct extreme temperature onto the skin directly, okay? Because that can cause harm to the patient. Also, some other treatments are reduction, like we talked about, the realignment, and traction, which we'll go into a little bit later. Now, the fracture healing process is listed over here. I'm not really going to go too big into it because it was never really that high yield, in my opinion, on the exams. This is just for your knowledge. And this part I'll let you guys read as well, because, like I said, this was not, like, there were bits and parts of this topic that came into, like, that were high yield, and these parts were not super high yield, okay? Now, we're going to talk about reduction and traction, the treatments of the fracture, right? So the closed reduction is a non-surgical realignment of the bone fragments. So there's traction and counter traction applied. So A common example of traction is the skin traction, also known as Buck's traction, and it's externally done and you're using weights attached to, for example, the foot, and it's going to pull the bone back into alignment. It's a short-term thing, but there are complications with skin breakdown, okay? So nursing interventions include like proper skin care, cleaning the site, and like doing a good visual assessment for any redness, or you know, um, palpating the patient's skin, all that good stuff. Skeletal / external traction. Um, I think they meant internal, but internal is surgical realignment of bone fragments using much heavier weight. So it's a long-term process, and there's a higher chance of infection, such as osteomyelitis, right? So you need to be on top of their white blood count when you get labs. You want to look at that. You want to look at promoting a healthy diet as well. And we'll also go into what is a healthy diet for these patients with fractures. Now, this was one of the topics that we got tested on a lot, or I would say a mild amount, because whenever I think of fractures, I just think of ORIF, because that was like the only one of the two big things that they taught us. So it was this and another topic that we're going to go over. But the nursing management for ORIF is, a PCA pump and opioids. These are really painful. So the PCA pump is the patient-controlled analgesia, and they have a pump where they can control how many doses they get, and it's set like you get 5 clicks an hour or 15 clicks an hour or whatever. There's also non-opioids. Toradol is a really popular choice, and obviously don't forget our non-pharmacological methods such as dimming the lights, ice packs, heat packs, all that good stuff. Also, we want to prevent respiratory complications, especially things like pneumonia, right? The reason for this is because when our patients have a broken leg or lower extremity, they can't really walk sometimes, and they aren't really exactly motivated to walk because the perception is that, oh, I need to stay on strict bed rest because that's like the public knowledge of health, which in some areas, and that's not always true. They like to mobilize patients pretty soon after surgery, okay? So some things that we can do to prevent pneumonia, though, like the respiratory complications, are incentive spirometer. My hospital's policy is 10 times every 2 hours, but I've seen other hospitals do 10 every 1 hour. Cough and deep breathe, and these can be quite painful, so don't be surprised if you see a question on the exam with an option to teach the patient how to splint with the pillow, where they will put the pillow against the surgical incision site. Like if it's like a hip, they will push down on it with a pillow, and they'll take the deep breath during that time. Or ribs, especially the ribs for this part. Splinting can be very helpful. Now, also we want to prevent DVTs. This is basically clots, right, in the leg. That's bad because if the clot breaks off, it's going to go right through the veins back into the heart and go into the lungs, causing pulmonary embolism. So what we want to do is we want to give them anticoagulants. So you're probably going to see heparin, Lovenox, all these good anticoags. Mobilization is also, like I hinted on, like they want to encourage early mobilization. And SCDs, these are the little massagey things that they put on the legs that kind of squeeze and pump the legs on during surgery, but you can also use them when they're in the room. And lastly, wound care, especially if it's like an open wound or if they're doing one of the realignments with bone and weight, okay, with like the pins and stuff. Now, the complication of CAS, this is the other thing that was like really testable. Compartment syndrome, right? So it can be caused by a decrease in compartment size or an increase in compartment contents. So basically what this means is that either like the limb or extremity or whatsoever is being casted on, it's like swelling inside, or you drop something inside, or the cast itself is like shrinking, right? Basically, this is a medical emergency, and the answer for questions would always be to contact and alert a physician, because they need to cut that cast off and relieve pressure, sometimes even going as far as a fasciotomy, right? The pathogenesis basically is saying that there's increased pressure that compromises the blood return and circulation in the nerves. So ischemia can be as quick as 4 to 8 hours, and if you don't take this seriously, the limb may need to be amputated. This is why it's a medical emergency and you need to let the doctor know right away. So what do you do to check, right? There's the 6 P's. Now this is super high yield. I highly recommend memorizing this and like writing this out a few times because you want to check for pain. And it's not just like, oh, I have pain. Yeah, you're gonna have pain when you break a bone, but I'm talking about like excruciating pain, pain that's breaking through, pain that doesn't seem accurate for the level of injury, right? Or pain that's worsening, right? Like to an extreme degree. Because if they're normally saying it's like 6 out of 10, 6 out of 10, 6 out of 10, and then suddenly it's like 8, 9, 10, 10 out of 10, and you already gave them medication, you need to, consider this as an option. Pallor, you also need to consider because it's, like I said, the decrease and compromisation of the blood vessels, so you're not getting blood return, right? You're not getting good circulation. Paresthesia, you're gonna have this numbness, this tingling. They're not gonna be able to feel it that well. Paralysis of the limb. Pulselessness is a big one. This is why circulation checks, like the pulse checks, are so big on these surgery patients, and especially if you have a fracture. And then if they feel like there's increased pressure, right? So like I said earlier, the treatment is to remove the cast or do the decompression, which is the fasciotomy. Now, an easy way to also remember the 6 P's besides the 6P acronym is overall just CSM, right? Circulation, sensations, and movement. These 3 things need to be intact for the patient to be okay. If one of these are not, there, your mind should immediately jump into the 6 P's, do a further focused assessment, and let the doctor know that you're worried about compartment syndrome. So the things that you can check are like the distal pulses, right? Like this is for the pulselessness, the color, the pallor, temperature. There's like poikilothermia. Cap refill is also a big one. Movement for the paralysis, and paresthesia, right? So moving on to vertebrae and vertebral immobilization, this is when they wear a body jacket brace, and the big thing that you need to worry about with this one is that you need to worry about the mesenteric artery, because the brace can sometimes compress on the GI tract, and you need to listen to the patient's bowel sounds to make sure that they're not having a reduction of blood flow and like have a normal active bowel sounds, okay? The treatment for this is an NG tube, but honestly this is pretty low yield, so if you only remember the 6 P's, like the CSM stuff, and also like a little bit of the ORIF treatments and how to like make sure you clean the wounds and the fractures, the weights being off the bed, they should never be on the floor, they should never be on the floor for the weights. This chapter goes a little bit into also the joint surgeries, such as these options right here. Honestly, this is pretty easy as long as you memorize like the root words. Like sino, you usually know that it means to do with a joint. So this, you can think of it like the synovial joint. It removes the inflamed tissue, and for example, in rheumatoid arthritis. Osteotomy, it's removing a part of the bone, because osteo, you want to think of like bone, right? To restore alignment. In OA, which is another type of arthritis. Debridement, usually when a patient has a diabetic foot ulcer, like it has dead tissue, you're removing the necrotic debris. Arthroplasty, it's reconstruction. Arthroplasty of the joint. It's reconstruction of the joint. So like hip arthroplasty is an example that you might see. That's like one of the more popular examples on questions. Post-op, some assessments, like I said, the 6 P's, right? Because you're basically wanting to look out for any compartment syndrome. Medications, it's the pain meds, anticoags, and preventing any infection. This is basically a summary of everything we went over, like treatment-wise and things we need to be concerned about. You want to prevent inflammation with rice, which we talked about how this is what the textbook's teaching, even though it may not be the latest in current practice. Incision care, obviously it kind of goes with like the antibiotics, keeping a clean site, performing wound care as ordered, and doing the dressing change as ordered, and obviously assist with mobility because of the weakness in the fractured area, and also potentially like the lack of circulation, the weakness in the joint and stuff in the limb. So the nutrition stuff that I mentioned earlier, these are the big ones. The big ones are like high protein, high vitamins. But honestly, if this is like too much to remember, just think like healthy diet, right? Like you want to encourage healthy stuff. The reason why you want to increase like fluids is obviously to keep them hydrated too, but also increasing the fiber, because if they aren't moving and on pain meds as well, they have like the opioids, they have a higher chance of constipation. So this is to also promote having a bowel movement. And if they have the body jacket, which we were worried about, the GI artery obstruction or decreased blood flow, you want to do 6 small meals a day, because you don't want to like have them overeating and having that stomach go way too crazy by like jutting out, right? Because that's going to compress against the jacket and be extremely uncomfortable for them. Alright, so next week we're going to be talking about musculoskeletal problems, but this is where I'm going to leave off for now because I already feel like this video is extremely long. Alright, good luck studying.